This podcast and content posted by Dr. Judith Joseph is presented solely for general informational, educational, and entertainment purposes. The use of information on this podcast or materials linked from this podcast or website is at the user's own risk. It is not intended as a substitute for the advice of a physician, professional coach, psychotherapist, or other qualified professional diagnoses or treatment. Users should not disregard or delay in obtaining medical advice for any medical or mental health condition they may have and should seek the assistance of their healthcare professionals for any such conditions. Dr. Aletha Maybank is a senior vice president within the American Medical Association as Chief Health Equity Officer, and she is the founding leader for the AMA's Center for Health Equity and is influencing the embedding of equity throughout healthcare ecosystems. Dr. Maybank uses her platform to emphasize solutions that honor the legacy of our ancestors while preserving our desires to rest and have joy. She has won numerous awards for her groundbreaking efforts. And on this episode of The Vault, we talk about being a woman in healthcare, being a professional woman, and dealing with infertility and perimenopause. I was going through a lot of IVF, and it was really difficult for me. And I'm someone who, I'm from the Caribbean too. I was born in Trinidad, came to this country with very little. So there's that scarcity trauma and just trying so hard to get everything right. Like first person to graduate college, first person to go to medical school, first doctor in the family. And it's just like, what do you mean I can't have a kid? I was like, what? I can do everything. And the doctor's just like, But when we start talking about these things like perimenopause, like menopause, fibroids, things that we think, and we are Caribbean, so like the lady parts, you're not supposed to talk about those,
right. And that's what they say, the lady
right.
parts, right? I'm just like, wait a second.
Right. And how to find gratitude and purpose in our work in spite of inequality and the systems that we work in. Dr. Aletha, thank you so much for coming onto the podcast today.
Absolutely. Thanks for having me. I'm very excited. It's awesome to meet you in person too. So
yes. I feel like I know you because I see you everywhere.
That's how that COVID kind of did that too. Sometimes I question, who did I meet them or not? And then folks will come to me, oh, it's the first time I'm meeting you. I'm like, oh yes, that's right. Let me act a little bit more, excited.
Well, you were like a doctor celebrity during COVID because you were literally everywhere educating about the pandemic and about health. And I think a lot of doctors have become heroes, but also very public figures because of what we've been going through over the past couple of years. And we were talking earlier about how there's such like a culture of suffering in medicine and how, from the standpoint of medical education, we're not supposed to be talking about a good life. We're supposed to be talking about, well, is the patient okay? Like, we do what we do for service of the patient, for sacrifice. And a lot of that is true, but two things can be true. We can have a good life and also help others.
Yes. And so I think it also builds upon, a lot of the work that we're trying to counter in terms of some of the narratives around, if you work so hard, you're going to get X, right? The myth of meritocracy as folks, as we know it, and we know it's a myth, right? And I think as physicians and as the medical community, it is very much harbored in that space, right? That we must work this hard. And I also think when you think about the roots of medicine, in terms of Western medicine, American medicine, very much led by men, white men who had opportunity, who have privilege, money, wealth passed down, perceptions that they didn't have to be, or realities that they didn't have to be in the home at one point in time. And some of that still transcends today. But as, women of color, and I'll just talk about us or me, it's not the case. We have so many more responsibilities. But I also think, for our generation, what becomes different is that, we are definitely standing on the shoulders of many folks who came before us and are right here at this present time doing justice work in very real and deep ways. We have been taught to work hard, and as Black women especially, in this concept of being an independent woman, and we have to do all these things by ourselves. Really understanding the reality is how well we're connected to one another. Our interdependence is very critical, for our success, and it's okay to be that way. But it's also okay to experience joy, right? And we should be, working towards our joy. I talk about during COVID, as you mentioned, I was working a lot. You did see me a lot on the virtual screen. I was really trying to take advantage of the time and the moment of being able to talk about inequities and anti-racism work, or racism and just in general as well. That was created by COVID, the exposure of inequities and the public murder of George Floyd. So I did probably that year of 2020, 120 virtual presentations. It was ridiculous. And that's not a normal thing, and it's not really a healthy thing either. But I also knew, at the institution that I work at, also in building a new piece and body of work, that you don't get these moments oftentimes. These doors open and they close, and we're kind of seeing that right now in our experience. And so as I was going through that, I started to also go to music therapy. A friend of mine, Gordon Chambers, who is in the music industry, was like, you need some support, you need some help. So I was like, let me go, let me try to sing and have some music therapy. You get to pick your song. And I love music. I grew up in the arts. And one day I came in because, he could see it on my face. And he's like, you come in and you talk about justice and freedom. And he's like, I get our ancestors were fighting for our freedom, but our ancestors were also fighting for our joy. And to that context, for our rest. And so that always hit me very deeply. And I shared it with my team. I shared it with whomever. And I really try my best to embody. It's hard, right? It's work, that you say but that. It's hard, yes.
I love how you talk about medicine traditionally was catered. It really catered to white men who had privilege, who had come from money. And it was something that, people did for prestige, but it wasn't something that they did because they needed the money, right? A lot of the forefathers in medicine, they came from wealth. And the idea of joy in itself, I think it needs a rebrand, because if you look at the major institutions who are studying the science of happiness, who are these men? Who are these leaders? They are white men. But I think for Black women in particular, we have it so hard, and yet we are able to cultivate Black joy. We should be the leaders in the science of happiness, right?
Well, that, and that's such a wonderful point as well. And I think that's a shift that we have to really start pushing forward in our narrative, and not accepting what people say about us. We as a people, I feel as Black people, we have made it through all of this, right? I'm not saying we're fully thriving, but what I will say, and maybe we are, in some aspects, when you look at what we bring to the world in terms of, and historically, in terms of arts and fashion and anything that's like creative, the beauty of a lot of it comes from our own ancestry. But we've made it to this point. And so, that context of resilience, I'm like, we already lived that. We embody that. I come from public health, and we used to always talk about, well, we have to help communities become resilient. I'm like, no, a lot of these communities actually really are resilient. And they have the tools, they have the strategy, they have the strengths and assets to figure out what is needed in order to, at least at minimum, survive and to thrive in many other ways, and to find and produce joy. And so we need to build upon that, I think, in this context of health, because oftentimes when we talk about health and health inequities and disparities, it's always in this deficit model, not in the, what's the strengths of a community? And that's how you build. Community organizing is about identifying strengths.
100%. I can't tell you how many times, at least in my training, in clinics and in hospitals, I would hear people saying, well, don't offer this person that because they're overwhelmed. They're in a position that, they're just trying to make ends meet. And I'm like, don't underestimate them.
Exactly.
Because, coming from where they came from a position of scarcity, they made it to this clinic, and they made it to a point where they could get you as a doctor. You know how hard that is? Don't underestimate people, and acknowledge their strengths and their wins, because, listen, a lot of the famous designers these days, they got their help from people who came from positions of scarcity, who just had that natural sense for what is luxury, what is style, and they didn't grow up with that, right? So we really shouldn't underestimate people. I love the rebranding of the thought leaders, right? Because I'm a bit tired of it. I'm a bit tired of seeing these numbers, Black people are this, Black people are that. Okay, but can we talk about some of the great things too? We do have to acknowledge the scary numbers, the depressing numbers, but can we also uplift, that's why learning about the history of medicine is important, because there are a lot of things that people that look like us were leaders in, but you don't hear that. You hear the negativity.
Yeah, and I think, a couple things came to my head as you were speaking. And when I think about, I'll just go first to us as Black women physicians, and I'm friends with Uche and Toyin and all these other and Stella. Like, I just think of all these women that as well that are just amazing physicians who, when I think of what they do for each other and what we do for each other, is all strength-based. It's all asset-based. We are successful in what we do because we have each other, I think, as a collective and as a group, and we've relied on one another. And we've been able to become more visible, I think, to your point that you mentioned earlier, and present, because we see each other. And we are encouraged by each other, and we encourage each other. And so I feel that our power will continue to grow in that way. And I think we're in a time where I think that's actually kind of scary for people.
I think it is too.
But we need to still forge forward and capitalize on what it is that we know, because and it's not only because we do have to recognize our privilege also now, kind of being in this space as physicians. There's definite privilege to that, and financial privilege for many of us, and access to people that others don't have. And I think what's important is that, we are in the spaces, in the tables, or at the tables, but we're creating our own tables. That's what I think really we need to start doing moving forward, and start really building the trust amongst ourselves to do that in ways of which we're not only just kind of, collaborating, partnering, but we're also building wealth together. That's what I would like to see in terms of a vision of creating space of joy and rest, health.
I do think we need to support each other. I just read this book by Dr. Joy Braden, Hartford.
Yeah. Mm-hmm.
She started therapy for Black girls.
Yes. Mm-hmm.
And her book is Sisterhood Heals. And I think it's a great book. I just highly recommend it. But she goes through the different dynamics of Black women, and how, like, when you make it to a certain place, you're looking around the room and you're like, well, there's only room for one of me. I can't tell you how many times I've seen that dynamic. But at the same time, I've also been in dynamics where it's like, I meet another Black woman and she's looking out for me, And I feel like if we could just do more of that, looking out for each other. Listen, there's enough for us all, right? If we could uplift each other. You don't have to go out and start an organization or join an organization, but, shout somebody out on social media, follow a Black woman. These are little things anyone can do to support another Black woman. But she talks about these complex dynamics that unfortunately do exist. And I've had other guests come on and talk about those similar things.
Yeah, I mean, that's a product sometimes of just white supremacy, right? And the tools and strategies that are used in order to divide any group of people, right, into other, or to think that somebody is against you or somebody's taking from you what you should have, right? The whole zero-sum concept. And so, I would say, I think there definitely are, we know that there are situations in which we are not as supportive of one another. But I would say, for the most part, overall, we would not be here if our families, our sisters, our aunties, our grandmothers, whomever, mothers, were not supportive of one another, and not only in the context of their family, but also more broadly of their neighborhood and their community. That is the foundation of who we are as a people, and we need to always remember that and embody that. When we get more into these corporatized spaces and we're in academic spaces, maybe there's that tendency sometimes to kind of push away from that or lose that. I think a particular generation. I think our generation is the one that's one right before us. Kudos to them. Clearly, I don't knock the sense that there were a lot of firsts, a lot of door openings so that we could be where we are. But there's also a context that's created with that sometimes, and that first, and wanting to hold on to being the first, and being told you're the first over and over again, and sometimes fearing what does it mean to let go of that identity. That was so important. And so I think, for our generation, it's important to understand that, just in having conversations. But for us, we can choose to do things differently. And I think many of us have done that. I mean, in the positions that we are, the work that we do, again, the joy that we experience. And I I just turned 50 years old.
Congratulations.
It's so hard for me to say. But I had to say it. I'm getting through it.
Listen, 50 looks very different than it did 20 years ago.
I guess, but it's still the number. But anyway, and I had over like 50 people come. My family's from Antigua. My mom's side of the family's from Antigua. And so they all came down. Like, it was so amazing. And what the beauty of it was is that you have different groups of friends in different places. As you've traveled, and you go to school in different places and you meet people. And I didn't have to do much, but those friends like became friends amongst friends. And now, and so when that starts to happen for us in terms from an emotional, social context, for me, I feel so grounded after that experience this past month. Work is hard. The context of what's happening in our society and our global culture is really rough. But I feel so grounded, because I'm grounded in my relationships and I'm grounded in knowing that I'm loved, and that I have people who care for me and that I can care for them. Like, there's nothing better than that. And it's not about me as the individual. It's about the opportunity to be this collective space. And that to me is the ultimate of everything.
I do a lot of menopause advocacy, and I work with a lot of people who talk about aging and turning 50. And, speaking of two things being true, a lot of the work has to do with like menopause being undertreated and underdiagnosed, but also a lot of it is positive in that aging, you find that you know yourself, you know who you are, you're feeling more grounded. You stop caring about things that you used to care about. So there are, positives to this, right? And a reframe that I think has recently happened. I think that maybe 10, 20 years ago, people weren't framing it that way. People wouldn't say their age. They wouldn't talk about aging. But now it's like empowering, and there's strength in numbers. I
think, and that's, yes, that's true. I'll get there, I promise. But I think just to bring in another context to it, and yes, menopause, anything related to women's health, if you think about it, has not been studied enough. Anything. Pelvic floor issues, like none of it.
Fibroids.
There hasn't been enough research. There hasn't been enough, advocacy, medical education. We just didn't learn, a lot about it. And for me, for infertility and fertility as well. And so I bring that up specifically, and maybe this is what you do at 50, that's different, is that, I think part of my reluctance about 50 is that I thought I was going to be someplace different at this point in my life. And I had to spend, I think, the last year, really accepting that I don't have children, and I really wanted children, and I always felt that is my purpose in life from the time I was a little girl. And then also in the context of, I'm still not really fully partnered up or married, and all these visions of what I had about where I would be at this point in my life. So that's a piece of it. Like, clearly my career, all those pieces, they're there. That will always be there somehow or another. I've always landed on my feet in that space. My friends, as I said, and family, I'm blessed and beautiful in that sense. But the context of having children is something emotionally that I've had to deal with. And we don't have that conversation as we're having it a little bit more amongst our kind of smaller groups of friends and, people who know me well know this story about me. But that we don't talk about that enough in our society. And we don't forgive ourselves. We don't give grace. And there's so many standards and expectations of who we should be, what we didn't do, what we must have been thinking, that I must have not wanted children, or I must have just wanted to focus on work. And I'm like, no, I didn't want to just focus on work. I've always had a pretty good balance of my life in terms of social and meeting people and being out there in terms of just friends and seeing what's, engaging in arts and culture. As well as working. But it hasn't panned out, and it didn't happen for many other reasons that, we always have to be honest about too. But we don't talk about those aspects and bring our full selves to the space. And I'm sure, as I'm 50, because this is the first time I've ever said this part of a conversation. You're getting a lot out of me today.
Well, I am a shrink, so.
Yeah, there you go.
Well, I did try to make a reel about infertility once, because when I was trying to have my daughter, I was going through a lot of IVF, and it was really difficult for me. And I'm someone who, I'm from the Caribbean too. I was born in Trinidad, came to this country with very little. So there's that scarcity trauma and just trying so hard to get everything right. Like first person to graduate college, first person to go to medical school, first doctor in the family. And it's like, what do you mean I can't have a kid? I was like, what? I can do everything. And the doctor's just like, it's going to be a challenge for you. And I was just like, it was the first time that I just couldn't, no matter what I did, I couldn't do it. And I was just like, why don't we talk about this, you know? And it was very lonely. I remember being in the waiting area and seeing someone that I knew. And I was like, oh my gosh, they're going to see me here. And I'm like, wait, but they're here too. You know, we don't talk about it. And it could be very lonely. But when we start talking about these things like perimenopause, like menopause, fibroids, things that we think, and you know, we are Caribbean, so like the lady parts, you're not supposed to talk about those,
right?
You know?
And that's what they say, the lady parts, right? I'm just like, wait a second.
Right.
That's how I'm referring to them? Okay.
But
I hear you.
We have to talk about
that's
it.
Right.
It's really difficult to be alone. And the Surgeon General, Vivek Murthy, he says, like, loneliness. Who knew loneliness was going to be the thing, right? Like, loneliness is gutting us. We need to feel heard. We need to feel connected. We could be in a room full of people and still feel alone.
Right. And I think, and that's the context of all the work that we've done, though. This sense of not being heard and seen, even in the equity work. You know, when you have large systems, structures, institutions, public health departments creating solutions outside the context of how people are, what they're really experiencing, what they really want and what they really need, we are not seeing and hearing. And I think it's a human condition. And really, kudos to Vivek for putting that forward, you know, because I think that's courageous, because there are a lot of folks who, and that he's had the support to do it. So that's also kudos to him to know the strategy behind getting things in place in that way. But to have a whole national strategy on how to address loneliness, I think is a great start to how we start to address just mental health overall in this country, and starting to build in a more inclusive narrative and normalize, you know, I don't know. And I think that would be an interesting thing also to think, maybe you've thought about that more. And that's part of, I guess, you know, the point of the podcast is just normalizing, just talking about whatever. Like
normalizing being a human.
Whatever,
right?
exactly. Whatever it is that comes to us, and that it's okay. It doesn't lessen us. We're all of the same value, that we know. And it's okay to experience any of this.
It is. And your position within your organization, focusing on equity, I think, you know, after what happened with Black Lives Matters and people like having so many DEI initiatives and then seeing those same initiatives shut down, I think within medical education and medical organizations, it's life or death. Like, we can't stop talking about this. Tell me about what you do.
We can't, but some people are forced. That's the reality. I mean, or else you will be punished. You know, it's sad, it's disgusting, it's bizarre. It's like, okay, you don't want the human condition to go that direction, you know. But, you know, working and starting the office, you know, at the American Medical Association, it's now 5 years. April made 5 years. Thank you. I hadn't expected, honestly, to stay that long. But again, the context of COVID, the inequities, public murder of George Floyd propelled, I think, for many of us who were, you know, in this space, like, we now had this platform, you know, to talk about racism, you know, and I pushed to white supremacy and decolonization, all those kind of things as well now. But, you know, capitalizing on that, I think, has been really critical in this role at this particular institution. It is one of the reasons why I came to the AMA. You know, I tell folks, you know, I was a National Medical Association member, and for those who are listening in don't know, National Medical Association was created because Black physicians were excluded from AMA for over 100 years. And so Black physicians created their own institution. And so, you know, I was in local leadership, even in NMA. So I was an NMA person well before AMA. I don't think I would have ever thought I would have come to AMA knowing the history and the silence also. It's not only the exclusion of Black physicians, but they were silent during the desegregation of hospitals, or the move to work to desegregate hospitals, and also bring in Medicare. And so, you know, now being there for 5 years, I'm able to see some level of impact. We were able to pass policies related to, naming racism as a fundamental cause of why health inequity exists. Naming and saying race is a social construct, not a biological construct. Getting rid of race as a proxy for anything because it's not a biological construct. All those are important policies and positions that AMA has put forward because AMA is still the largest healthcare lobby. It's highly influential. And so I knew that coming in, and that if I didn't know COVID was coming and we didn't know, the public murder of George Floyd. So that just helped efforts. And so, been able to capitalize on that. But now in this time, I think what we've been able to do is kind of be a resource, I would say, for many. And this is more so a relationship thing. I don't know if it's necessarily AMA or Aletha Maybank and the Center for Health Equity or some of the other teams and staff members at AMA who people, really trust and reach out to. But we are starting to hear from folks across the country who are experiencing the shutdown of their programs, what they have to do to evolve their language. Like I heard the other day, folks have to be called like Chief Impact Officer or Chief, I heard a really interesting one. It's just something completely not even in the line of naming equity or justice explicitly. So, I think it's ever more critical that we are continually operating in a collective state, solidarity, learning from one another, advocating, voting, and I get it's hard. I understand in many ways. That's my political comment, not AMA's comment. But too many people fought for that opportunity for us. And I think, especially when you come from not being, you have family that's not from this country or you're not from this country and you're in the other country. And you kind of, for me, like just what my mom, really came here for, who calls me every time it's a voting day and said, did you practice and exercise your right? It's so critical for us to do that. And we know the health impacts from a structural context, from laws and policies, but just even a wellness context for voting. And it is discouraging on many levels for many people across this country who are being suppressed in terms of the voting situation. But I don't. We are still in a democracy at this moment in time. It's unfortunately threatened.
It is.
Right? Mm-hmm. But we need to still do what we have to do to support the democracy as much as we can. And there are many different ways to do that. It's not just voting.
We can't get comfortable. We absolutely cannot. This is really a crucial time for us. And, you have access to so much information. What's one of the most surprising things you've learned in terms of equity and inequity and within healthcare in this country?
I think, that's
a hard one.
I don't know if it's surprising. I think it's part of our challenge is that there's such a wide variety of understanding about how health is produced. And so overall how health is produced, so just the context of the political determinants, like there's such a lack of understanding of the policies and the structures and the politics and how that influences almost every single thing we do. And then there's this movement within medicine, and we were kind of trained like this, that we're not supposed to talk about the politics and that health for some reason isn't political. And I'm like, health is highly political. I said all of organized medicine who influences policy and financing and investment in health at the federal, state, and local level all interact with politicians. That's the root of what AMA does. That's the core of what we do. It's the core of what all of organized medicine does. So we, as physicians, not being knowledgeable in our political system and the environment and what creates, and produces that healthcare system that you want to be working in, but the larger context of health, because it's also about everything else, transportation, jobs, wealth, all those things, housing. We being ignorant to that is not helpful, I think, for us as a physician community and for our country at large.
It's not. And the fact that we have a medical degree separate from an MBA, separate from an MPH, well, doctors need to know all those things, right?
All of those, yep.
Yes, because we know how to diagnose, we know how to memorize, but we don't know how to run a business, and we don't know how hospitals work, and we don't know how to get things covered for our patients. That is not okay. That has to change. I always ask my guests about a time in their lives when they were struggling on the inside, but on the outside, everybody thought they had it all figured out, that they were so put together.
Can I say now?
And how did they get through that?
As some folks know, I wrote a piece that was published in the New England Journal of Medicine, I think in March. And it was a struggle to get that piece published, which was very interesting to me too. You know, the privilege that I've had, I don't know if it's AMA, but I had that even beforehand, I think, because of the leadership roles that I rarely get no's, you know, in terms of public. And I kept getting no's. I'm like, what is going on? So finally, you know, through a kind of a relationship connection, New England Journal, you know, said that they would, they evaluated it and it went through a whole peer review process, but they said they would publish it. And I really wrote the piece because it's been one of the harder times. This last year has absolutely been one of the toughest times in my career. There are days, and I've said this, I actually wrote a piece before that one that was much longer. That was a love letter. And it was framed as that and named as that to other equity and DEI leaders. That, you know, I really see you and I really, you know, feel exactly what you're going through. And there were days, you know, that I just didn't feel okay. I didn't feel okay. The weight of navigating the external environment, having to help my team understand and maneuver through the external environment, and being in an institution that was figuring out how to navigate the external environment. You know, my other colleagues and other members and, you know, folks who were against what we're doing and folks who are for what we're doing and thinking we're not doing enough, as I said in the piece. So my mom, you know, is 88. She's a pretty good 88, but starting to, you know, show signs that she needs support. And she's asked for, you know, more support. And as an only child, I'm like, how do I fit all this in, you know, and meet her needs, and then meet this job. And, you know, I think, as I said, I just came back from my 50th birthday celebration, so that did feed me, and being around family and friends. And I think I'm talking about it more. You know, a lot of times, to your question, folks don't think anything is wrong, right? And I have to take responsibility for that too. You know, I kind of move through and feel, especially when you're a leader at a certain level and at an institution, a lot of times I have to show up for my team in ways where who cares about how I'm feeling? You know, I have to show up for the team. I have to show up for the work. I have to show up for the institution. I have to do all these things. And it's like, you know, Aletha's emotions, you know, are secondary, tertiary, you know, to all of that. And so I don't share it. Yeah. And so I'm doing my best. I'm not saying I'm optimally there yet of sharing, you know, with family and friends, you know, when I'm going through something, because otherwise they won't know and they'll think I'm fine. But I feel they're more clued in now, and, you know, they'll reach out. But this is, I think, as for many equity leaders, this is like a tough time. And doctors. I mean, yeah, absolutely. Mm-hmm. For physicians, for a while, even before COVID. But COVID, you know, sent the workforce like over the edge, the healthcare workforce overall. But speaking of physicians, because that's what we are, even more so. And then so, you know, you have COVID, Then you have, this healthcare system that's still not working for most people. So if the system is not working for the people, it's going to create stress and burnout for the physicians and those who are working in that environment. And then layer that on with inequities and all the taking and stripping away of rights of all types in this country from a legal basis. It's chaos. It's chaotic.
It's easy to feel powerless. It really is as a physician. But I think that as a leader of physicians like yourself, saying it's okay to not be okay. It's okay to say, I need a break. I need support. People listening to this who are doctors, they're usually the ones in their families that people call, right? Like, I'm the only doctor I was for a long time the only doctor in my family. And it'd be like, hey, this is happening. What should I do? Hey, so-and-so was doing this. And, check on your strong family member. Check on them because they need help too. They need support. They're human.
Yeah. Yes. And I think that's right. and then we have to also ask for it. I think we need to also do that too and allow our armor to go down in ways that we're not used to. Because we're also, and that's there, and there's layers to that too, as we already talked about earlier, as being a Black woman, but also just the nature of being a physician too. You're not supposed to, have emotion in that way. Not that you're supposed to care, but you're not supposed to have emotion. I was a hospitalist when I finished residency, pediatric residency. I didn't know fully what I wanted to do with my life, so I kind of bought time. And worked as a hospitalist in New York City in the NICU, in the neonatal intensive care unit, and I love kids, but what I just remember standing over a bed of a baby, and when you're in the NICU, babies are going to pass, like that's just it's a given, and I remember not crying. I just remember just standing. I don't laugh. I'm not laughing at it, but it was just a reflection that I had one time standing over the bed, watching the parents, almost as if I was outside of my body, watching their emotional process and knowing it was a really rough and emotional process, but not being able to even participate with them in that. Mm-hmm. When that to me is like a more natural human way of being. And so I always knew that wasn't right either. And I didn't want to. I really didn't want to be that. I pushed away from, medical culture and practicing and the context, at that time, especially that I wasn't supposed to care about my patients and where they lived and the conditions that they lived in. And I'm like, how do you care for people fully if I don't know what that is and I don't care about that? That is not care to me. And so, I went back to my public health roots. I went to Hopkins undergrad at Hopkins back then because I'm older and I'm 50. They didn't have public health majors. We actually went to the public health school as our undergraduate major. And I remember just being so moved and inspired at that time by those courses because they were talking about something very different. It wasn't the basic and clinical sciences that we were focused on, which is what medicine is focused on. The Flexner Report of 1910 focused on that. That's a whole nother conversation in a historical context of AMA. But, this social context just really kind of really filled me. And I understood that, this is like the totality of how we need to be talking about health. And so that propelled me to kind of go into public health, to go into preventive medicine, do another residency, get my public health degree. And then I transitioned into, governmental public health and had these other opportunities as they move forward.
Well, what you described, that numbing, right? That lack of emotion. I mean, it's a defense mechanism. And before I was a psychiatrist, I did anesthesiology residency and 1 year of internal medicine because now they combine the programs. But back then, it was 1 year of internal medicine, 1 year of anesthesiology. And the amount of trauma that went unprocessed. You're supposed to see someone code, do CPR, see death, and just take on the night shift, right? There is so much unprocessed trauma in medicine, and we're just told to go, that after a while we stop feeling. And it's a defense mechanism. And I'm studying right now high functioning depression, which is not yet recognize, but it's essentially,
I think a lot of us got that.
essentially it's you have all these symptoms of depression, but you don't have the option of slowing down. You have to be on go. And I think so many physicians, I think so many healthcare workers deal with that because they are programmed to care for everyone else but themselves. And I think that's a problem. People are more comfortable using words like burnout because there's no mental health stigma there, right? We all burn out. We just have to freshen up.
Yeah.
But some people are taking that break. They're taking that vacation and they're not coming back refreshed because they have unprocessed trauma. They are not dealing with what's happening. And if we don't take care of our healers, then how are we going to be healed?
Yeah. And then that's the question. How do we take care of our healers, and what's the best way to do it? And we can go, the route. And I know there's, there's a lot of work AMA is doing, as it relates to that. And it's beyond just, we need a meditation class, or Headspace. And not to knock Headspace, because Wisdom Pal is at Headspace and she's doing awesome work. I'll come back to that because I think that's going to be my next thing to talk about. But this context that, it's just going to be these kind of downstream tools, that were being promoted at first. I think now there's a greater consciousness that it's about the structures and it's about the system that's in place and it's things within the system. If we don't change the system, you don't change the realities of what can feed the context of burnout. But I think to your point, there's something even deeper than that, that within the system of caring for people, there's a whole emotional context of which some parts you're fed in a good and solid way, but so much extraction as well. Extraction in your sleep, extraction in your knowledge, in your emotions. And we don't know. And then all the trauma layered on that, that we do see and experience. There's no trauma-informed supports, right? There's no supports. There's no system for that. And people are poorly trained in even understanding, what that is and the need for that.
And the fear that you have to report, well, you have to report if you're struggling. And then for people who, especially like myself, coming from scarcity, it's like, but I went through all this medical school, I have all this debt. What if I report that I need help and then I can't pay off my debt and then I can't support my family? It's like people are set up to just not want to ask for help. They're set up to push through. And I think that if we as physicians don't allow people to actually address their issues on a daily basis, right? Not just one workshop here, not just one retreat here, but like a daily thing, like, okay, if you're struggling, we have to talk about it. You can lean on someone for support. It's okay. Let's normalize this. If we don't do that, we're going to have a whole generation of healthcare workers that burn out. Don't come back.
Yeah. And I would say we've already had that, right? I think it's just the magnitude of it is just higher at this moment in time. I think healthcare workers have always been burned out, and have always been tired and exhausted at some point, in ways that just haven't been discussed or talked about. But I also think about, for us, what are other opportunities for healing that are available. So, I've been going a lot to Montgomery, Alabama. There is a brilliant artist, Michelle Browder, who created the Mothers of Gynecology. It's this powerful, piece of work, art, really in honor of recognizing the horrific history of the experimentation, and that's the light term to say, of enslaved women at the hands of J. Marion Sims, who was from the South and really the self-proclaimed father of gynecology, or maybe other people proclaimed him as such, who created the speculum that we use to this day, and has gotten a lot of credit and praise, but did all these procedures. And she said and reclaimed history and the narrative to say, well, we need to honor the women who were tragically tortured, experimented on, you name it. And so Betsy, Lucian, and Arca have a place in Montgomery. And so when you go to this place, it's the Moore Up campus. It's not only about the monuments that she has there, It's about the space for healers. And it's not just about physicians. Now, she has a primary interest, I think, in physicians because of our own supremacy as physicians, and also the context of J. Marion Sims, but is very much interested in kind of creating that link and interconnectedness intentionally with doulas and with midwives and with nurses and all of that. So we as health professionals can learn from one another and can heal and grow with one another. And, she even bought the property that J. Marion Sims did some of his procedures on and is converting that now to a health center where these students would kind of navigate through. And so, every time I go there and every time I bring groups of folks there that are physicians or leaders doing this equity work, we always leave transformed further and inspired that we actually have the solutions within our communities and ourselves of what we need for ourselves.
Wow.
And that to me is quite powerful. And then I was mentioning earlier, Dr. Wisdom Powell, who's at Headspace, has been thinking a lot about what does it mean to have a mindful neighborhood. I believe place and where we live is a good kind of start. We can do things individually, but I believe everything is about the collective. Like we don't really do things individually. We think we do, but we really don't.
We're not in silos.
No. And so this context of like, what does it mean to build a mindful community? And it's also building off of the assets. So like who in your neighborhood do you go to get information? Like who's that person that, you think about to get information, or you go to have a safe space in your neighborhood, like in building from there. Like I think it's brilliant. And then there's also Andre Perry, who's doing work at Brookings on the Black Progress Index, again, looking at the assets. So he looked at cities across the country, Black cities, and seeing where Blacks are living the longest. Yeah. So let's look where we're living the longest, see what's happening there, what are the assets and strengths there, and how do we build from that? That to me is a more mentally satisfying thing to do and validating thing to do because it values us as people, that we actually can do it. I'm not saying that inequities still don't exist because we already know the wealth gap. However, there are places that we know that we do live longer. And so what happens there and how do we kind of replicate that and feed that?
Yeah, I do think that not everyone likes traditional therapy, and there are other ways of healing, like learning about reclaiming history, using music, even animals, like equine therapy, traveling. These are things that feed us, and not all of us are going to be ready to sit down and talk to a therapist, but at least we can talk to a friend, we can talk to a colleague, we can reach out to a mentor. We need to share some of the burden. Where can we find you and follow you and look at what you're doing in the future?
You can find me in Antigua.
I like that.
That's my goal. That is my goal. I'm not been on social media as much, but I am on LinkedIn. And I do that. I do Dr. Aletha Maybank. It's like my profile on Instagram. And then I'm on Facebook as Aletha Maybank. So, yeah.
Thank you so much. I learned an incredible amount of information, and I'm just so grateful for everything that you're doing and for you supporting physicians and Black physicians. So thank you for coming on to the
Thanks
podcast.
for having me. And thanks for all that you're doing, seriously.
You're
doing a lot. Thank you.